So in this lecture, we're going to be going through the serous fluids, which is it's a comprehensive group of fluids. It includes fluids from 3 different cavities in the body. You have your pericardial fluid, which is the fluid surrounding that is in the sac surrounding the heart. We have your pleural fluid, which is the fluid found in the sac surrounding the lungs. And finally, the peritoneal fluid, which is also known as PD fluid or peritoneal dialysis fluid. These are fluids that surround the sac that contains the gut. Okay, so we're going to go through the pericardial and the pleural fluids first, because they're a little bit different in the sense that we get them a little less frequently, and there's going to be less of them when you do collect them. So just to remind you what the purpose of having a fluid-filled sac is, you have a sac that surrounds a particular cavity, and then there's fluid within that sac. And normally in these sacs you have truly a very small amount of fluid that's sufficient for the purpose of cushioning and keeping things, sort of preventing over movement or too much movement of a particular organ or organ system. It also helps to bathe those organs. However, the amount of fluid that we normally have in those sacs is so small that it would be actually very difficult to collect any fluid from those sacs in normal situations. But from time to time, fluid does build up in these sacs. Happens, we have what you call an effusion in the area. An effusion or a buildup of fluid in the sac can be for one of 2 reasons. Either a change in the osmotic forces that are surrounding the organ, either on the outside of the organ changing the forces, or the organ itself calling for more fluid. Those changes in osmotic forces cause an increase of fluid production, which the fluid consistency doesn't change, and that's called a transudate. The other situation we might find is we do again have a buildup of fluid, but this is due to a change in the permeability of the membrane. That means if you have a change in the permeability of membrane, then you would by definition have a change in the constituents that make up the fluid. Generally what we see, and these are called exudates, and generally what we see are increases in proteins, cellular counts, and sometimes bacteria. We would find in an exudate. So when we have an increase in fluid, or when we have an effusion around the lungs or around the heart, we need to collect that fluid, if possible, and send it to the lab to be able to differentiate a transudate from an exudate. Okay, then there's a reason for that. Transudates, as a general rule, there's nothing we can really do to treat the actual osmotic changes directly. Whereas in exudate, there's usually a significant, maybe infectious or inflammatory reason for that, and there's treatment that's necessary for that. Okay, so those fluids are going to be collected. In the case of the pleural fluid, which is in the cavity surrounding the lung, that will be collected via the process of thoracentesis. So one of the things you need to remember is that sometimes you get a fluid down, it'll say thoracentesis fluid. You need to know that that's a pleural fluid. Okay. Pericardial fluid, which is in the cavity surrounding the heart, is collected via pericardiocentesis. Same thing, aspiration of the pericardial fluid. So the labeling of the specimens, it really should all be done on a barcode these days, and most of the time it is. But every once in a while you get somebody who still handwrites, and they might write something, maybe you have to harken back, but at least now you know you've heard of it before. The other reason that we might collect these, the only other thing we would do with the transudate, remember it's not caused by any infectious or inflammatory situation. However, one of the reasons we need to drain it is also because, of course, a buildup of fluid along these cavities, if the buildup is enough, you are going to affect the actual function of the organs within that cavity. You know, if you have a whole bunch of fluid building up around your lung won't be able to expand. And a whole bunch of fluid around your heart is going to affect the ability of your heart to beat. Now, there are some markers that we look for to be able to differentiate transudate or exudate when we're talking about these fluids. When we look at the markers, the things that we're looking for, is this just still an ultrafiltrate of the plasma, just more of it, or has the constituents of the fluid changed? One of the things that we do look for is specific gravity. The normal specific gravity for a fluid is usually less than 1.015. So as long as that stays around there, you have pretty good evidence that this is likely a transudate. You can look at the fluids and frequently tell the difference. If the fluid maintains a normal looking color, clear, okay, it's not cloudy, and it has that pale yellow or straw color, you're probably fine. An exudate, however, some of these fluids can get very cloudy, very gross looking. So obviously if you have patent blood in there or some thick mucus in there, obviously there's something extra in there, so that would be an exudate. Some of the numerical things that we need to look for, if we look for protein levels, we would compare them to serum protein levels. Okay, normally you have about half the protein in the fluid versus the serum. As long as it stays that way, you're probably a transudate. If it increases, exudate, and that's a simple ratio. Okay, LD levels, you can use that. Again, 2/3. This is a little bit less specific, so 2/3 of the upper reference limit for serum LD. You're doing a test on the pleural fluid, but if you relate it to a normal serum level, is it about less than 66% or more than 66% of what we'd expect in the normal serum? And then you have these other things. The ratio, you can make a ratio between the fluid and the serum LD. Same thing with bilirubin, cholesterol. But the big marker that we tend to use are the appearance and the cells, because we have to do them on every fluid that comes in anyway. We don't do an LD, we don't do a bilirubin or a cholesterol level on every specimen that comes in. So if you only see a few cells, which is perfectly normal in serous fluid, you're probably still a transudate. If you have a lot of cells in there, though, that's not normal. So there's definitely some inflammatory response going on. Okay. Now, what would cause these different things? Well, exudate is usually caused by either some infectious disease, some infectious process, an inflammatory process. So there are several inflammatory processes that can occur, or potentially also some kind of cancer, which would lead to inflammatory process, and so on down the line. Transudates do still occur, but what's their number one cause? Well, there's usually actually some kind of organ problem that would lead to the transudate production. So, for example, congestive heart failure, CHF. It's not uncommon for you to see a buildup of fluid around the heart of somebody who has congestive heart failure. The liver, it's not uncommon for you to see a buildup of fluid around the liver in cases of cirrhosis or some kind of chronic liver disease. Okay, and that's what so they're not infectious in and of themselves, but the changes in the functioning of the organ lead to a change in the osmotic forces across the membrane, and you end up with more fluid. If you do have a transudate, that's pretty much, you're done with that fluid. There's not a lot of other testing that you need to do for that fluid. I mean, you still have testing related to whatever the disease state is, but as far as the fluid goes, we're not going to treat the fluid. It's there because of some secondary disease state. So you'd have to treat that in order to relieve the issue. But if it's an exudate, that's different. If it's an exudate, we need to look further into that fluid to find out, well, what are the cells that are increased in there? Is there bacteria in there? What's going on? Why is this patient producing a different type of fluid than would normally be there. Okay, so you would still have work to do if you are if you are deciding that this fluid is actually an exudate. So when you get a serous fluid down, the key things that we're going to look at, we want the specific gravity. We need to have that. We want to have the cell count. Cell count is going to be the most important thing on any fluid that comes down. After that, a protein level is something that we would definitely like to see. We don't usually test the specific gravity or the LD. Those are special. But in the order of importance, appearance, cell count, protein levels. Those are things that we're very, very interested in any serous fluid that comes down. So the gross exam that we're going to have, this just like urinalysis, we do a gross exam at every fluid that comes in. It's generally reported by one of the labs, maybe hematology, but every lab should certainly take note of it. But we don't report it 3 times. We just let it'll depend on the procedures at your lab, but hematology usually takes care of it. So the things that we note: color. Where urine has normal colors, so do serous fluids. Serous fluids are generally some kind of like light yellow to straw color, and they should be clear. They shouldn't have any cloudiness to them. One of the things that does happen with some body fluids, serous fluids, especially if it's an exudate, you can see clots, and we would always want to note that clots are there. If you have a clot, that means you have coagulation factors. If you have coagulation factors at a large enough percentage to clot, that's a pretty good sign of an exudate. Okay, so those are things that you would want the doctor to know. So again, normally if it's a transudate, remember the appearance is relatively normal. It's usually clear to yellowish. Yellowishy straw is the color I always think of. Whereas an exudate, mostly those are going to be cloudy, and you're going to see color changes. Everything. This is pretty classic of an infectious serous fluid. You can see it looks like pus. It's a gross green color. You can see this is very common for peritoneal dye. This is all received from one patient. You see that thick, cloudy gray, well, whatever, tan color is pretty gross. That's not normal. Here's your clear yellow specimen, perfectly normal. Okay, and then if you do see clots, you do have to mention them. If you have clearly visible pus, so like in this situation here, and you can even see there's foam on top of these. That foam is actually associated with increased protein that's present. Pus is this nasty green, yellow kind of, can even be thick white looking buildup. That's called empyema, and that's literally, it means pus in usually in the pleural space, but is where you're going to find it. Probably not going to find as much empyema in the pericardial space, but buildup of pleural fluid is not uncommon with a patient who has pneumonia. So we see pneumonia frequently, and you will get a specimen, and you might report it as empyema. Okay, so you know what that word was. When it's bloody or cloudy or turbid in any way, remember what we do is we spin it and examine the supernatant. Okay, it's important for us to be able to differentiate the cells and pull them out and still look at the color of the fluid itself. If your turbidity clears completely, then you can report what the supernatant looks like, and your turbidity is likely due almost entirely to cells. However, sometimes that turbidity doesn't clear, and that has to do with the fact that these fluids can develop chylothorax or pseudochylothorax. The chylothorax are these milky white fluids, frequently found mostly in pleural fluids, less often in pericardial fluids. but it's like a milky kind of coloring, anywhere from white. You can get some yellowish tinge to it, maybe even some green. They're not all that common, but they're thought to be, the chylothorax is thought to be caused by leakage from the thoracic duct. Usually due to some kind of malignancy, some kind of lymphoma, some kind of carcinoma. Although it has been seen in some traumas, especially following surgical trauma. So chylothorax you would report if you've spun that cloudy specimen and the supernatant is still cloudy. It doesn't clear. Okay, it's not a case of cells. So you might report that as a chylothorax. There is also a report of a pseudochylothorax, but we report that in the case of some kind of chronic effusion. So we would report pseudochylothorax because a pseudochylothorax gives you the same look, but you know you don't have a leak from the thoracic duct. What you have is likely these chronic effusions due to maybe some rheumatoid pleuritis or some tuberculosis is another one causes pseudochylothorax. The key thing is you know it's been spun down, the specimen, and it hasn't cleared, so you're going to report it as either chylothorax or pseudochylothorax, and in many labs they just stick with chylothorax and let the doctor figure out if there's a leak in the thoracic duct, because it wouldn't be, we wouldn't necessarily know if that's there. Okay, now the blood cells that might be there, most of the time what we get, if you look at this green, you might have some red blood cells in there, probably lysed, but these grayish yellow ones is probably mostly white cells and protein. When you have red cells in these fluids, now remember we're specifically talking here about pericardial fluids and pleural fluids. So if you're talking about red cells, you're thinking, oh, is there a hemorrhage? Now, a hemorrhage around the heart is certainly an emergency situation. So is a hemorrhage around the lungs. We don't want that buildup of pressure. So we look at those as an emergency situation. We've got to figure this out pretty quickly so we can help this patient out. It is possible to have a traumatic tap where the clinician, when they enter the space, they hit a capillary and they pull out some blood. And what you would see with a traumatic tap, it should, with each tube that you look at, should have progressively less red blood cells. But the other causes that are obviously the things we're worried about have to do with malignancy, pulmonary infarct, which is a clot in the lungs, or pulmonary embolism. That would be dangerous as well. That leads to an infarct. A rupture of an aortic aneurysm, any kind of chest trauma, pancreatitis and tuberculosis. These can all cause hemorrhagic fluid or bleeding into the sac around the lung. When you have that, it is possible, depending on how much red blood cells that you have, you could run a hematocrit on these patients, on these specimens, and you would do that mostly in a pleural fluid because that's where most of our hemorrhage issues occur. If your hematocrit is greater than 1%, usually that's going to be where we're going to associate it with some kind of either a malignancy, an embolus, or a trauma. That's usually somewhere just above 1%. But if it rises above 50%, true 50%, that will be associated with a true hemothorax. When we're really talking about something that has 50% red blood cells, then we know, okay, there's definitely a serious bleed going on here into this pulmonary space. So yes, you'll see hematocrits greater than 1%. Remember, we're not really even supposed to have that many red cells in these serous fluids, so seeing greater than 1%, there's issues there, but greater than 50% is a major problem. Now, the cell types that you're going to see when you look at the microscopics of serous fluids, these cell types, and remember, you can do cell counts using instruments, but in some cases, depending on the procedures at your lab, especially if it's a low cell count, you might get your hemocytometer out. in which case you might also perform a cytospin, where you can then stain the cells to look at them under the microscope. So remember what we're trying to do here. We're trying to differentiate transudate, exudate. If that's what we're trying to do, exudate, inflammatory process. So we're trying to look for those cells that are associated with an inflammatory process. And if you look at, they're not going to look any different in the in a fluid than they do anywhere else. So if you know your cells from hematology, you'll be able to identify them here. These are just some interesting things that you might see in a fluid that you wouldn't necessarily see in a peripheral blood. So in this case here, what we're looking at is a clump of mesothelial cells. No reason for me to know that. I'm a microbiologist. I have no idea about cells. But mesothelial cells are the lining cells of these sacs. So making sure that we don't overstep our bounds, that we always remember, we're very good at identifying blood cells. I don't want to misidentify a non-blood cell as a blood cell. So remember your limitations and always ask somebody who's better trained than you if you're not quite sure. These same mesothelial cells can become neoplastic, and these are pretty, look at how abnormal these are. They're multinucleated, obvious problems with these cells. So these are the same kind of cells, but they're they're neoplastic. Other things I think that mostly stand out here is the way that the cells stick together. So in the process of collecting the specimen, obviously a certain number of mesothelial cells are going to become part of it. So this is probably just what we happen to be looking at on our slide. One of the other things that, remember, we don't see these in the peripheral blood because macrophages don't exist in the peripheral blood. But so you need to be able to understand that this is not the peripheral blood. Fluids can have macrophages. And you can see the macrophages, these large vacuolated cells that I would favor they would look a little bit more like the monocyte. Well, they start as a monocyte with that sort of formal nucleus. It's not segmented, but look at all the vacuoles. That's what a macrophage does, right? It engulfs things. So recognizing a macrophage, because you will see those when you get to a fluid. That's not uncommon. And then within those, especially in an effusion where you're talking about some kind of infectious process, you can see, look at the engulfed bacteria in these cells. Never ignore those. If it's not a gram stain, though, don't forget you can't report it as gram positive or gram negative. So here, in this picture, we're looking at engulfed bacteria, and you might want to say, oh, those are gram positive cocci, but this isn't a gram stain. So don't go down the wrong road here, okay? Remember the limitations of your stain. You can say intracellular bacterium noted, and then let micro figure out what kind of bacteria it is, okay? So that's or you could say intracellular inclusions noted, even if you couldn't differentiate between a bacteria and maybe something else, okay? So all of these things are written up in what you're allowed to, how you're supposed to report these things in the procedures in your lab, okay? And again, especially at Sloan Kettering, where you have so many transformation events with your patients. If you see a cell that looks weird, you have some of the greatest resources in the world working with you, and you have cell division. Send it to them so that they can help you identify it properly, okay? So again, these are just some basic examples here. All the other stuff you need to know what a red cell looks like. There's a red cell right there. You need to know what your generic white cells, these just look like monos here that are in the rest of the organ and the thing. Here's some segs. Nothing special here. They look the same. You just have to remember your QC and the stain limitations. You also have to do QC. So when you perform a Wright-Giemsa stain, for example, What color are your red cells? What color are your white cells? If your red cells are not really red in your stain and they're really approaching purple, then I think maybe you're not in the right part of the slide. You're in a part that's too thick, and you should go to where the cells are in a single layer. If there is no place like that on your slide, you probably need to repeat the slide. You really shouldn't be reading areas of the slide where the cells are all packed together one on top of each other, because that will interfere with your interpretation of any one individual cell. Now you're going to have to do the cell count. That is the most important test that you're going to do on any fluid that you get in. Okay, the cell count really gives us the most information, and it's a very immediate way to help us differentiate transudate from exudate. Chemical analysis, however, is also going to be useful, in particular the protein levels. All transudates and most exudates will have a glucose of greater than 60 milligrams per deciliter. Okay, if you have a lower glucose, specifically one less than 60 milligrams per deciliter, that's highly indicative of tuberculosis, some kind of malignant disease, or some kind of rheumatoid disease. So not specific, but less than 60 is it's a warning sign to look closer. You're talking then about an exudate, and we need to look into what the cause is. The total protein levels, just to go back to this here, we already had that chart on the second slide that told us where we're looking for the total protein in the LD, how we use that to differentiate between transudate and exudate. Remember, that's our major function with these ones. Just to note, glucose levels on a pericardial fluid, generally speaking, we don't do glucose on a pericardial fluid only because we haven't seen any clinical value to measuring it. So you'll probably do it on, you might do it on a pleural fluid, but on a pericardial fluid it's less useful. pH, normal, slightly above perfectly normal. pH, so you have slightly above 7, which is a little bit higher than blood because there happens to be a bicarb gradient between the compartments, between the lung and the lung compartment and the blood compartment. We actually do use pleural fluid pH clinically, and the reason is that we want to try and determine if you have a parapneumonic effusion that needs to be drained. If you have a pH on the fluid of your pleural fluid, if that pH has dropped significantly, it might be important for us to drain that fluid. Okay, remember your pH is going to affect the exchange of oxygen across the tissues, and so if it drops too far, and generally speaking, the hospital will have a threshold, but that threshold will probably lie somewhere between 7.1 and 7.3. So if it loses somewhere around 0.3, 0.5 pH, then you'll likely need to, you won't, but the physician will likely need to change that or drain that fluid. Because pH is an important factor to test, it's important for us to remember that pH is affected by, the fluid pH is affected by exposure to ambient air. And so when you're talking about a difference of only 0.3 on the pH scale, exposure to air can have a significant effect on that reading, which means the specimen needs to be collected anaerobically in a vacutainer, something like that, to make sure that it is not exposed to ambient air. And then the pH be measured. You can just use a pH meter to do it within 1 hour. In most hospitals, we use the blood gas analyzer, which has a pH meter in it, and we use that to measure the pH on all of the pleural fluids that are collected. Okay. Again, pericardial fluid, doing pH measurements, it doesn't have the same effect because you're not exchanging oxygen across the heart tissue, you're exchanging it across the lung tissue, and so pericardial pH measurements generally not done. You see, we don't get pericardial fluids all that often, as you know, relative to the other fluids that we get, and the tests that we do on them, pretty much just the cell count to determine transudate or exudate. Okay. And also, again, we try to figure out if a fluid is it has the presence of certain lipids in it as well. In particular, the presence of chyle, which contains chylomicrons. These are those specimens that have that white haze. And what it actually consists of, what chylomicrons actually consist of, are a whole bunch of triglycerides in the pleural fluid that actually give you the same effect, this milky, this hazy white effect. And the presence of chylomicrons helps us to determine if an effusion is a chylous effusion containing chylomicrons or a non-chylous effusion. And we would test lipid levels in order to determine that. Okay, if you get a lipid level, a triglyceride level greater than 110 milligrams per deciliter, generally speaking, that's our cutoff. If it's greater than that, it's a chylous effusion. A pseudochylous effusion, generally less than 110 milligrams per deciliter. Okay, we also, and this presumes, of course, we have to presume that your blood cholesterol is about normal, somewhere, you know, less than 200. Okay. You also have to assume that the blood does not contain any chylomicrons. So what does that mean? Well, chylomicrons, which are just basically these triglyceride molecule kind of things, are frequently found in the blood, particularly after a meal. So don't let the patient shouldn't be eating before this process anyway. But if the patient just ate, you might see chylomicrons. So we're really looking for a fluid specimen collected from somebody who's obviously their blood lipid levels are normal and that they haven't eaten lately, so we don't get any interference from those things. And again, we do this testing from time to time on pleural fluids, not on pericardial fluids. And just to point out, lipid levels, you wouldn't have to do them at all if it did not appear milky white. Okay, the milky white coloring is that we use that. We have to determine chylous, pseudochylous, what's going on here. But if it's a clear specimen, there's no need to do lipids at all. Okay. Okay, enzymes. There are enzymes that we might do on pleural fluids in particular. Again, less commonly in pericardial fluids. And the two that spring to mind are adenosine deaminase, or ADA, which we actually do this as sort of another screening test for patients who have tuberculosis. Okay. This one you might do on pericardial fluid, but you're not as common as the other, as the pleural fluid. If the ADA is greater than 35 units per international units per liter, that is highly indicative of a tuberculosis patient, and greater than 40 is the mark off for pericardial fluid. Okay. But you will see elevations of ADA in other disease situations. So in PIMA, which we said it was when you have all that pus due to an infectious condition, or if you have a malignancy, rheumatoid arthritis, that should be SLE and brucellosis and Q fever. Those all are potential causes for an elevated ADA. Amylase is another one less commonly tested, but it has been found to be increased in certain pleural malignancies, as well as pancreatitis, pneumonia, tuberculosis, cirrhosis, and esophageal rupture. The way that we set the ranges for this, if the amylase is considered to be elevated when it exceeds the upper serum value, or if you do a simultaneous serum measurement, if the fluid level is 1.5 to 2 times the serum level, it's considered increased or elevated. Okay. Again, all you're seeing when you have an increased amylase is you're saying, oh, I have an effusion here. Doesn't point to any particular source, though. You can see that they range from malignancy to trauma, so it's a little bit varied. Non-specific indicators. That's all these are, non-specific indicators. Fluids are frequently sent for microbiology testing. And of course, every fluid that we get should be treated as if it was sterile. And by that we mean that if something grows out of a fluid culture, then we presume it to be infectious and we work it up. Okay. When you do set up a culture for fluid, you have to cover for aerobic as well as anaerobic organisms. Because you can get infections with either. Generally, what we see are infections of those organisms that are most closely associated, physically associated. So they would be either residents in the pleural or cardiac situation. You're talking about residents of the respiratory tract, okay? Less commonly residents of the gut, but you do see residents of the respiratory tract in there. These would also be considered critical lab results. It's not normal for anything to be growing in a pericardial or a pleural fluid. So if something does grow, or if you do see something on a gram stain, you report it to the physician under the critical lab result reporting procedures. Okay, and although it's not included in routine culture testing, we do perform mycobacterium and fungal cultures, which are separate orders, in order to cover for mycobacterium, which obviously can be found in pleural fluids from time to time, especially, and fungal cultures, which also, there are several fungus that also can cause pneumonia. Okay, but these would be separate orders. We wouldn't necessarily know them. You know, the doctor has to tell us that he suspects these things. This is a gram stain from a fluid, and what you're looking at here in the background, this is the stroma of the fluid, this pink background. It's just the proteins and all the things that make up the fluid itself, and that's generally how it stains. And then you look at the white cells that are contained within it. These are nucleated cells. You can see this is segmented, and then you have some lymphs or other mononuclear cells, maybe macrophages, that are here engulfing the gram-positive cocci in chains that are present. Okay, this is this happens to be from a pleural fluid of a patient who had strep pneumo, or Streptococcus pneumonia. Okay. And what are the things that are going to cause? These are just a couple of graphs that show you what causes, in this particular case, where their pneumonia comes from. These were literally findings of pleural fluids, not just the lung tissue, but pleural fluids. And so you can see it's pretty, well differentiated. You don't have half of the pie belonging to any one particular group. Strep malariae group, which is in our Viridans strep pile, and then you have 8% other. Okay, 5% I think other over here. So there's a lot of things that can cause the various infections, and these are just the breakdown from 2 particular hospitals. Now, if we switch to peritoneal fluid, we look at this a little bit differently because peritoneal fluid comes from the peritoneal cavity, but it's not really a cavity, not in the truest sense of the word. It only actually becomes a cavity when fluid starts to develop, when it starts to accumulate in it. Okay, so it's not the same as the pleural fluid, the pleural cavity and the pericardial fluid. Okay. When the fluid starts to accumulate in the patient is said to have ascites, which is why peritoneal fluid or PD fluid is also known as ascites fluid. Okay, it's because that's actually the disease state that the patient is known to have. And that fluid that's normally in there should be an ultrafiltrate of the plasma. So if it builds up, which can happen because, again, changes in osmotic forces. You could have increased pressure somewhere. Maybe the patient has congestive heart failure or something like that. That can actually lead to a buildup of fluid in the gut. Okay, but if there's no infectious or inflammatory process going on, then it'll just be a transudate. Okay, it should still look like an ultrafiltrate of the plasma. If, however, when you get this fluid, it has increased cells in it, bacteria or anything like that, then we know that it's an exudate and we have to figure out the cause for it. Okay. The process by which it is collected is through paracentesis, and there's, well, technically, there's, what happens is the fluid builds up in the patient's stomach, and actually most of the time you can't even see it. It's such a large cavity and nothing to do with the size of the patient, but there's so many places for the fluid to hide. So it's very difficult to get the fluid out of this space. So what they do actually, and remember it's just filled with a gut full of bacteria, you don't want to nick anything in there. So what they frequently do with paracentesis is they take a bag of just sterile saline and they use that to flood the patient's gut, and then they collect it on the other side. Okay, they drain it from the same side on the other side. And what that allows you to do is to wash out the fluid and anything that's causing a problem in the patient. But the key thing to remember there is you have to add something that's going on to the patient in order to get this out of the patient, okay? And you're going to do paracentesis when you can see that there's a buildup of peritoneal fluid and you want to rule out things like bacterial peritonitis or maybe some kind of malignancy in the abdomen, something like that, okay? Whatever the cause of the ascites is, you want to be able to identify it. So if you just directly collect the specimen, it's called paracentesis. If you add the fluid and then wash it out, that's actually called a peritoneal lavage, okay, which means peritoneal wash. We only need about 30 milliliters for lab analysis. Cytology usually wants cells as well, especially if they have to be able to rule out any kind of a malignancy. But it's not uncommon. I showed you those cases where you got liters upon liters of fluid. That's what you added. The washing out process can be helpful for the patient to wash out all that those infectious soluble and cells, all that stuff. So it's not uncommon to get more and more liters going into the patient and then draining them back out again. The gross exam for a peritoneal fluid is similar to the gross exam for any other serous fluid. You're looking at a clear, straw-colored fluid, and if it's a transudate, it's going to stay clear and straw-colored. Okay, it's not going to change. Most common cause for a transudate of peritoneal fluid is cirrhosis, so liver issues. Okay. Exudates, however, they're not uncommon. We get cloudy, gross-looking peritoneal fluids all the time. And that's because infectious processes of the gut are not uncommon, whether it's a malignancy that causes inflammation or an actual infection that causes inflammation. It still can cause an exudate, okay? And we have a few colors here that you can see. Is it just cloudy? Maybe that's an infectious process. If it has any red color to it, you're worried about hemorrhage. Milky and white, that's the chylous effect. You're worried about those, not really worried about them, but you're thinking chylomicrons. Evidence of a hemorrhage But really viscosity, if your PD fluid has become very viscous, that's a good sign of mesothelioma. And then if it's got any kind of color green, like a bile color of green, gallbladder, do you have, is your gallbladder giving you trouble? Or pancreatitis, that can also happen. Anchovy paste color, not really sure what that is, but actually it's you have a problem with the liver, okay, and usually it's associated with an infection. And then chocolate sauce, it can get really gross. That's an abscess in the peritoneum. Again, the cells that you're going to be looking at, the same cells as anywhere else you would look in your, hematology or anything like that. They're just found in a fluid. The neoplastic cells that you might find in a pleural fluid, you might also find them in a peritoneal fluid. Okay. For atypical lymphoid cells, these are reactive, right? The lymphoid cells are doing something. Well, that's a possibility if you have some kind of viral infection or some kind of neoplastic event where the lymphocytes are trying to attack infected cells or transform cells. Here's your mesothelial lining cells again, okay? The key thing, the thing that always points out to, or jumps out to me is, look, they're connected together like a lining cell should be. Here's some more neoplastic cells. You can see the change in the nucleus is really weird, and you've got this bubbly reactive cell lining. Okay, here's your regular neutrophils down here. Nothing unusual about them. 1, 2 neutrophils are there. Here's some macrophages that you might note, and some monocytes. And then here's this is actually a gram stain, this last one, and you can see the gram-positive bacilli found in a peritoneal fluid that was submitted. Patient had a Clostridium infection. Now the PD fluid is also going to be to occasionally have some chemical exams. This presumes that you understand a protein level is very useful because we like to be able to differentiate transudate and exudate. Glucose levels less useful in a PD fluid, probably won't order that at all. But our most important test is still going to be the cell count. We've got to get that cell count done, okay? So there are a whole bunch of markers available. Your hospital will not use all of these. They will pick 1 or 2 of them in order to differentiate transudate from exudate. And remember, that's our major purpose, okay? When the first line, or the most common test that we use is still the proteins, albumin. So the SAAG is the serum ascites albumin gradient. And that's what we use primarily in order to establish, is a PD fluid a transudate or is it an exudate? Okay. When we perform this, you need a serum that's collected at the same time. You're going to do your, you could do a total protein and an albumin level on these, very simple. When you just do a total protein of less than 30 grams per liter, historically has been considered a transudate, and over 30 grams per liter was considered an exudate. But this was found to be, it was kind of an oversimplification, and there were a whole bunch of exceptions that you had to include in that definition. So they moved to this SAAG, this albumin gradient, in order to get a better picture. So what you're comparing is the serum albumin level with the fluid albumin level, and calculate a gradient based on those measurements. If you have a gradient of greater than 1.1, then generally that indicates a transudate, because and it's probably caused, again, number 1 cause is cirrhosis, so probably caused just by high pressure, high hydrostatic pressure. Okay, if it drops below 1.1, though, that's usually associated with an exudate, some kind of malignancy. Okay. Now, there are other tests that could be used. It'll be up to your hospital to decide which tests are most appropriate. Between the lab and the medical board, they'll decide what's most appropriate. Obviously, the presence of bilirubin is not really normal anywhere. So if we have increased bilirubin in the peritoneal cavity, we would want to know about that. If you do have bile in the peritoneal cavity, that's called coloperitoneum. And it's pretty simple. Normally, you should have less than 1 milligram, between 0.7 and 0.8 per deciliter in the peritoneum. And a normal ratio, if you compare it to the concurrent serum level, somewhere between 0.38 and 0.44, okay? If you start to get a lot of bili in your peritoneal fluid, that's actually usually a sign that something's going on with your gallbladder. And when we have a ruptured gallbladder, which is, of course, emergency situation, we tend to see very high bilis, greater than 6, that kind of thing, with a ratio greater than 1. That would be fairly indicative of a gallbladder issue, okay? If you have a bilirubin that's greater than our normal, anywhere greater than our normal, we do tend to associate that with an exudative process. The key thing is, you're not able to substitute bilirubin for the SAAG. You would only use bilirubin to try and pinpoint the reason for an exudate as potentially a gallbladder. The other markers that we have here, amylase and lipase, those we use those to indicate the possibility of pancreatitis. They're, again, not very specific, but they help to turn a doctor away from maybe the gallbladder and start to look at the pancreas, okay? And the concentrations that we're looking about, PD fluids generally about 3 times above the serum reference value. Lipase, you're going to use it in conjunction with amylase. You have to look at both of them in order to determine if the patient has a pancreatic issue that's causing the peritonitis. Okay. Cholesterol and triglycerides, they have been used in the past as markers for malignant ascites. That's more difficult to it has not been something that's been well researched and well supported by research, I should say. Okay. The key thing that we use the cholesterol and triglycerides for is to help determine a chylous effusion from a pseudochylous effusion, in the same way that I talked to you about that before. So an increase in the triglycerides, it would be, and remembering that the patient has to be fasting, they have to have normal lipid levels. Is that chylous or is it pseudochylous? Okay. LDH levels are often compared to serum levels it's used as another marker for malignancy, some kind of neoplastic event occurring within the PD cavity. With pH, that's not incredibly useful. They have used it to demonstrate some kind of bacterial infection, but a gram stain works a lot better than that. Okay, so it is possible you can grab a pH if you need to, but it hasn't had the same success as microbiology studies. Okay. Lactate is another marker that has been proposed, although it's not widely used, and that's because research has shown that it is significantly higher in the infected, in those who have an infectious process going on, than those who do not. And you'll see as we get to them how hard it is to compare white counts. You think, well, if they have an increased white count, they must have an infection. But you have to remember there's other things that are non-infectious, meaning not caused by bacteria, that can lead to an increased white count. Again, we said that glucose is fairly limited in a PD fluid, so it's generally not tested. And alk phos, remember that there's a lot of alk phos activity in the GI tract. That's where the liver is. That's where these things happen. So if we wanted to use alk phos as a marker, it would probably be most useful to use it when we're looking for the cause of peritonitis to be some kind of mechanical or physical blockage. We've seen the highest levels or the most increased levels in cases of obstruction, strangulation, or perforation. Okay, so those are the reasons why we might test alk phos. In microbiology, again, you're going to treat the specimen as sterile. The difficulty with PD fluids is the fact that you do get perforated colons, so you can get a whole bunch of flora dumping into the peritoneum from the gut. This is very common in appendicitis. It's very common in colorectal cancer. It's very common even as patients in the elderly, they get obstructions which lead to a leaky gut. And so when we look at the gram stains from these places, we need to note, there's so many different bacteria. At other sites, we might be tempted to say mixed bacterial flora greater than 3 types, and I don't want to look at this anymore, but it's still a sterile site, and unless your procedures say that you can just report it as a mixed flora, you have to work up everything. Okay, and this here it's a little bit better picture. You can see the white cells, and you can see the gram-positive cocci. There's some gram-positive bacilli going through, and there's potentially a bunch of different organisms in that. This is what it might look like on a plate. This happens to be an SS plate. When you do plate a PD fluid, it's not uncommon to throw in an enteric plate so that you can look for the pathogens that we have to be afraid of, like salmonella. Okay. And I guess they took this picture and they put it up to try and sell the plate, and then they have somebody who's got great big long fingernails, which you are not supposed to have in microbiology, because as everybody who gets their fingernails done knows, this is a breeding ground for fungus, and if it's this close to the agar, the fungus are on there. Okay, so in this particular plate, if this was a peritoneal fluid, you're going to work up everything. Okay, and you can see we have one large yellow colony, we have small yellow colonies, and we have black colonies. So you would have to work them all up to be able to determine what they are, because nothing is supposed to be outside of the gut.